Bienvenidos a nuestra serie de webinars 2021 del Colegio Argentino de Cirujanos Cardiovasculares. Estos encuentros incluirán presentaciones destacadas y paneles de discusión sobre una variedad de temas relevantes a nuestra especialidad. Nuestra intención es hacer de estas reuniones lo más interactivo posible. Los invitamos a acceder a la sección de preguntas y respuestas en nuestro chat en Zoom. Nuestros moderadores y panelistas tratarán de responder y aclarar todas sus inquietudes. Por favor, tengan en cuenta que esta webinar está siendo grabada y estará disponible en nuestro canal oficial de YouTube, CACCB y nuestra página web. Muchas gracias por acompañarnos. Esta webinar comenzará en breve. Por favor, les solicitamos silenciar sus micrófonos. Muchas gracias.
¿Cómo estás vos,
Bien.
Javier? ¿Comienzo yo?
Sí, creo que ya estamos. Belén, ¿estamos en el aire?
Así es, doctores.
Gracias. Bueno, buenas tardes a todos. Comenzamos nuevamente la serie de webinares 2021 del Colegio Argentino de Cirujanos Cardiovasculares. En esta oportunidad, junto con la Sociedad Argentina de Neurología, vamos a participar en unas controversias con respecto a todo el manejo de la enfermedad carótida. Realmente en esta oportunidad tenemos unos profesores de primera que creo que hay que utilizarlos en el buen sentido porque saben tienen una gran cantidad de información acerca de lo que es la patología. Yo voy a presentar básicamente a nuestros dos moderadores y ellos presentarán al doctor Ross Naylor y a David Spence, que van a realizar sus presentaciones. La doctora, por un lado tenemos a nuestra amiga archiconocida, doctora Cristina Zurrú, del Hospital Italiano, además de la Sociedad Argentina de Cardiología, de Stroke, y por el otro lado al doctor Marcelo Pataro, también otro amigo, cirujano cardiovascular, del Sanatorio Itois. Y bueno, caballeros, pueden ustedes introducir a los speakers y muchísimas gracias por esto.
Vos primero, Cristina.
Buenas tardes, para nosotros es un orgullo poder tener al doctor David Spence con nosotros. Es alguien con amplia experiencia en Doppler carotidio y en tratamiento médico de la enfermedad carotidia, proveniente de Canadá, de la Universidad de Western. Es aparte farmacólogo y vamos a disfrutar mucho de la charla que nos pueda dar. Por favor, David. Está muteado. Ahí está.
Perfecto.
Perfecto, sí. Puede
It's mute.
comenzar.
Can you hear me now?
Yes.
Yeah, sorry about that.
Yes.
It's an honor to be invited to this meeting and thank you for the invitation. So I'm going to talk about optimal medical management of carotid stenosis. Here are my disclosures. They're really not relevant to this topic. So the issue is that in patients with asymptomatic carotid stenosis, the risk of stroke or death is now lower with intensive medical therapy than with either endarterectomy or stenting. Here is a meta-analysis of a number of registries, and you see the risk with surgery or stenting in general is greater than the risk of medical therapy, which is only 0.5%. There are a number of studies about this that are mentioned on this slide, but most asymptomatic patients cannot benefit from either stenting or endarterectomy. So here are the data from this phase 2 trial. Medical therapy was much better than either endarterectomy or stenting. Now, how can that be? And the reason is that modern intensive medical therapy is much more effective than the therapy that pertained in the past when the NASCET trial and the asymptomatic carotid artery surgery trial were conducted. What does it consist of? Well, it starts with lifestyle modification. And lifestyle is much more important than most physicians think. In this American study, a healthy lifestyle reduced stroke by 80%. That consisted of not smoking, moderate alcohol intake, a healthy weight, daily exercise, and a diet in the top 40% of the diet score. And unhealthy behavior accounts for more than half of stroke. Here's a Swedish study in men with hypertension and hyperlipidemia. A healthy lifestyle reduced cardiovascular events by 80%. Now, we began first in, it says 1990. The first time we measured plaque in our lab was 1986. And measurement of carotid plaque area was invented by Maria Di Sico, our technologist. And we found that among patients in our prevention clinic, during a mean follow-up of 2.5 years, there were a lot of deaths, a lot of strokes, a lot of MIs. And people had said, well, this is a small study, it's only 1,686 patients. But we had as many events as in the first 10 years of Framingham. So it was a powerful population. And we found that patients in the top quartile of carotid plaque, which was 119 millimeters squared or 1.19 centimeters squared and above, the 5-year risk of stroke, MI, or vascular death was 19.5%, whereas the risk was much lower in people with less plaque. And we also found that half the patients had plaque progression in the first year. Now, our patients in the prevention clinic have far more plaque than healthy volunteers in the Tromsø study in Norway. So if you look at the difference in the x-axis, our patients have 3 or 4 times as much plaque as healthy people. They're very high-risk people. And in the first year of treatment, half the patients had plaque progression, and the ones with despite treatment, and the ones with plaque progression had twice the risk of those with stable plaque or regression. So this meant that medical treatment was failing in half the cases, and those with progression had twice the risk, so we needed to do better. So in 2003, we implemented this approach that I call treating arteries instead of treating risk factors. The goal of therapy is not simply to achieve an LDL target and a blood pressure target, it's to stop plaque progression or achieve plaque regression. And this starts with showing patients images of their plaque, explaining how severe their plaque is, that it's much worse than other people of the same age, that the plaque can be treated, it can regress, and plaque regression markedly reduces the risk. It involves lifestyle modification, it involves intensive medical therapy that includes statins to the highest dose that's tolerated, adding ezetimibe, sometimes adding evolocumab, antiplatelet agents, anticoagulation in the appropriate patients. Pioglitazone turns out to be a big factor in causing plaque regression, especially in patients with prediabetes, reinforcement of the lifestyle changes. So it is a process that's very intensive, and it depends on first showing the patients images of their plaque, which markedly improves their adherence. And there's been a study in Sweden in the Lancet a couple of years ago, reporting that showing patients pictures of their plaque markedly reduces their Framingham risk scores. Now, what does this accomplish? In patients with asymptomatic carotid stenosis, we reported in 2010 that after we implemented this approach in 2003, the percent of patients who had microemboli and transcranial Doppler decreased from 12.6% to 3.7%. And microemboli and transcranial Doppler are a very strong predictor of stroke risk. The rate of plaque progression declined significantly. There's the Kaplan-Meier plots of before and after 2003, significant reduction in risk after 2003. The presence of microemboli still predicted risk. But here's what happened. In 319 patients with asymptomatic carotid stenosis, the risk actually was more than that. After 2003, the 2-year risk of stroke was only 1% compared to 8.8% before 2003. So there was a more than 80% reduction in the risk of both stroke and myocardial infarction after this process was implemented. Now, this is not only done in our lab. Here are results from Argentina in prevention clinics across Argentina in health maintenance organizations run by a company called Blossom DMO from Cordova. And they had enrolled between 2011 and 2015. The number of patients went up from 1,675 to 2,000. They implemented treating arteries in 2012. And the annual risk of cardiovascular events in patients over age 65 went from 5.85% to 2.35%. So this can be done in Argentina. And it is done in Argentina. And here's my slogan that I published years ago: treating atherosclerosis without measuring plaque would be like treating hypertension without measuring the blood pressure. So the deal is that severity of stenosis does not predict risk of stroke in asymptomatic stenosis, although there's a paper from Oxford recently opposing that view. So how might we identify patients with asymptomatic stenosis who could benefit from intervention? And there are a number of approaches that are listed on this slide. And I think perhaps in order of importance, but microemboli and transcranial Doppler, ulceration on 3D ultrasound, plaque composition, reduced cerebral vascular reserve, intraplaque hemorrhage on MRI is emerging as an important predictor of risk. So here's our paper from 2005. Among 319 patients with asymptomatic stenosis, 10% had microemboli on 1 hour of monitoring. That's 2 microemboli in 1 hour of monitoring. The ones with microemboli had a 15.6% 1-year risk of stroke, which is much higher than the risk of either stenting or endarterectomy. So the risk of endarterectomy is about 2%. The risk of stenting is about 3%, 30-day risk of stroke or death. The ones without microemboli had only a 1% risk, so they cannot benefit from intervention. Here's the Kaplan-Meier survival curve. There was another study published in 2010 from Hugh Marcus, the ACES study, which was a multi-center study that had actually 1 patient fewer than we did. We had 468 and they had 467. They identified microemboli on 1 occasion. If patients had 1 microembolus, the risk was not quite as high as those with 2 microemboli, but there was still a clear distinction between patients with microemboli and those without. Even after implementing intensive medical therapy in 2003, the presence of microemboli still predicted risk. Here is ulceration, which is identified much better on 3D ultrasound than on other modalities such as angiography or MRI. We published in 2011 this paper reporting that patients who had 3 or more ulcers on either side, it didn't have to be the side of the stenosis, had a very similar risk to those with microemboli. So here's the risk over 3 years. With 3 or more ulcers, the risk was about 20%. With microemboli, it was about 18%. So very similar. And very interestingly, only 1 of these patients had both microemboli and ulcers. They're different phenotypes. Now, occlusion of the carotid artery is not a ticking time bomb, as many vascular surgeons seem to think. Doing endarterectomy for the purpose of preventing occlusion is not a valid indication for stroke. Here's what happened to the percent of patients with carotid stenosis who went on to occlusion after we implemented treating arteries in 2003. The occlusions nearly went away, but the risk of stroke at the time of occlusion was only 0.3%, which was well below the risk of either stenting or endarterectomy. So the circle of Willis works very well, and preventing occlusion is not a valid indication for endarterectomy. So most patients are better off with intensive medical therapy, and endarterectomy or stenting should not be done without evidence of high risk, such as microemboli, ulceration, intraplaque hemorrhage, or reduced cerebral vascular reserve. In the future, we'll be imaging vulnerable plaques with various modalities, including inflammation of plaques on PET MRI. So those are my remarks. Here's my email address if anybody wants to send me an email to ask for any of these papers that I've referred to. And thank you for your attention. How do I unshare? Stop sharing. Okay.
Muchísimas gracias, David. La clase excelente y cómo viene cambiando todo el manejo desde la implementación de un mejor tratamiento médico en estos pacientes, ¿no? Vamos a dejar las preguntas para el final del auditorio y ahora seguimos con la presentación del doctor Naylor Ross.
Bueno, buenas tardes. Un honor y un orgullo estar acá, haber sido invitado por el colegio, y gracias, Javier, por moderar esta charla de estos dos grandes profesores que tenemos aquí. Me toca a mí presentar al doctor Ross Naylor. Cada vez que escuchamos ese nombre, los cirujanos vasculares, ya sabemos que es el principal especialista en carótida a nivel mundial. Así que el doctor Ross Naylor es cirujano vascular, profesor de la Universidad de Leicester, y nos va a tocar un tema como es este, un tema candente, que es la estenosis carotídea asintomática, que como ustedes saben, y después de esta excelente charla de David, es una entidad que no existe en este momento ningún consenso ni ninguna claro que haya que ser invasivos con la misma y tratarla. Así que vamos a escuchar al doctor Naylor, a ver, y nos va a explicar a ver qué relación existe entre los pacientes con estenosis carotídea asintomática y deterioro cognitivo. Así que, doctor Naylor, un gusto escucharnos. Muchísimas gracias.
Thank you very much. I hope you can see my screen. I'm here to talk to you about asymptomatic carotid stenosis and cognitive impairment. Now, you will know that there's been a great amount of controversy about the intervening in asymptomatic patients in order to prevent stroke. But what has also been controversial is this trend towards suggesting that intervening with stenting or surgery may prevent cognitive impairment. Now, 7 years ago, the first systematic review on the subject was published, and this showed that 9 out of 10 studies reported an association between asymptomatic carotid stenosis and cognitive impairment. But of course, what this could also mean is that asymptomatic carotid stenosis and cognitive impairment share similar risk factors. Now, why is it difficult to evaluate cognitive function? Well, few of the studies use a comprehensive cognitive domain testing, and this is largely because they don't involve neuropsychologists, so they tend to use easy, generic, simple neurocognitive testing. And many of the tests may be inappropriate to the hemisphere being tested, so that if you have a right asymptomatic carotid stenosis and the test you use predominantly looks at the dominant hemisphere, don't be surprised if there's no abnormality. There's also a tendency to combine symptomatic and asymptomatic patients, and there's often a lack of controls. Most studies are too small, There's no standardized timing for the post-operative assessment, and follow-up is often too short. And virtually no studies correct for what's called a practice effect. And this is that when you do repeat testing, you get better at the cognitive scoring because you're getting a practice effect. So in order to try and get greater clarity on this subject, a group of us undertook 2 systematic reviews. The first is the relationship between asymptomatic carotid stenosis and cognitive impairment. And the second is on the effect of carotid interventions on cognitive function in asymptomatic patients. The first paper has now been published in the June issue of the European Journal, and you can access it. We identified 35 studies of purely asymptomatic patients with over 3,500 patients and nearly 11,000 controls. There were 30 cross-sectional studies and 6 longitudinal studies. Now, interestingly, 33 out of the 35 studies, at 94%, reported that there was a significant association between asymptomatic carotid stenosis and cognitive impairment. 20 studies reported that 1 to 3 cognitive tests showed impairment. 10 studies showed 4 to 6 tests with impairment, and 3 studies reported that more than 7 tests showed cognitive impairment. But I want to make this very clear. Identifying a significant association does not mean that there is a causal association, i.e. that the asymptomatic stenosis may be a marker of something else rather than being an actual etiological factor. So how might an asymptomatic carotid stenosis cause cognitive impairment? Well, it may be through silent cerebral infarction, silent embolization, involvement in the pathophysiology of white matter hyperintensities on MRI, and through a hemodynamic etiology. And I'm going to look at each of these in turn. What about silent cerebral infarction? Well, in this slide, I'm dealing with both cortical and lacunar infarction, and there have been 2 major meta-analyses. The top one found no association between silent cerebral infarction at baseline and minor cognitive impairment, but it did report that silent cerebral infarction was significantly associated with developing dementia. The lower meta-analysis performed an identical evaluation and confirmed that there was a significant increase in the risk of dementia with silent cerebral infarction, but once they corrected for repeat cognitive testing, all statistical significance disappeared. So that there is no, if you allow for a correction for practice effects, there's no evidence that silent cerebral infarction is associated with increased risks of dementia. Let's look at it a little bit more critically. Here is silent cortical infarction. Now, none of the 35 studies reported that asymptomatic patients with cognitive impairment had higher rates of ipsilateral cortical infarction, which is surprising, but only 2 studies evaluated this. So there may be a causal association, but no one has actually looked at it properly. And in some studies in our systematic review, the presence of silent infarction was an exclusion criterion. We know a little bit more about silent lacunar infarction. The Tromsø study mentioned by David showed that those with 35 to 99% asymptomatic stenoses had poorer cognitive function association with a higher prevalence of lacunar infarction. However, there's been a very good study called the Osaka study, where 44% of 506 controls and 47% of 94 patients with asymptomatic stenosis who had normal cognitive function at baseline had a lacunar infarction. And over the next 8 years, about 10% developed dementia. And Cox's multivariate analysis showed that lacunar infarction at baseline was independently associated with a higher risk of developing dementia, but a 50 to 99% asymptomatic stenosis was not associated with dementia in the presence of a lacunar infarction at baseline. We also know, and this is not asymptomatic patients, but if you look at a meta-analysis of 12 studies on the patterns of carotid disease in 2,873 patients with lacunar infarction, only 8.8% had an ipsilateral internal carotid stenosis versus 26% in non-lacunar strokes. And most of these were found after a risk adjustment to be associated with small vessel disease, which is what many of us were taught. And in a separate study, the overall rate of carotid or cardiac embolization in nearly 200 patients with lacunar infarction was 11%, with the other 90% being attributed to small vessel disease. What about silent embolization causing subclinical brain injury? Well, the Manchester group have done a number of studies on this subject. They took 144 dementia patients and performed transcranial Doppler and then cognitive testing every 6 months for 2 years. And they found that there was a significantly greater decline in cognitive function in patients with spontaneous embolization. And the spontaneous embolization predicted more rapid progression of dementia over 2 years. Now that sounds quite significant and important. But while the spontaneous embolization in dementia patients was associated with worsening cognition, there was actually no association between the prevalence of asymptomatic carotid stenosis, embolization, and dementia. And in particular, dementia patients who had spontaneous embolization rarely had a greater than 50% asymptomatic stenosis, that was only 15%, while only 5% had a greater than 70% asymptomatic stenosis. And interestingly, most of these patients in this study had a venous to arterial shunt. And this group did one other interesting study where they took 96 slightly older patients with no evidence of dementia at baseline. And again, they did transcranial Doppler for embolus detection, followed by serial cognitive testing for 2.5 years. At baseline, 12% had evidence of silent embolization, but there was no association between silent embolization and the development of late cognitive decline. A subject of great importance is the pathophysiology of white matter hyperintensities on MRI, as you can see in the scan in the top right. If you do have white matter hyperintensities, this doubles the incident risk of dementia, as well as faster declines in overall cognitive performance, executive function, and processing speeds. This is well documented. So the question is asymptomatic carotid disease associated with the pathophysiology of these white matter hyperintensities? Now, the Tromsø study showed that patients with asymptomatic carotid stenoses did have significantly poorer cognitive function, but when they looked at the patterns of white matter hyperintensive severity, it was equally distributed amongst patients with and without asymptomatic carotid stenosis. And in a meta-analysis of 11 studies with over 6,000 patients, there was no association between patterns of white matter hyperintensity and ipsilateral asymptomatic stenosis or bilateral disease, absolutely no association at all. That leaves us with a hemodynamic etiology. Now, I just want to explain the concept of impaired cerebral vascular reserve. As a carotid stenosis becomes more severe, patients with a non-functioning circle of Willis and poor collateralization compensate for this by progressive vasodilation of the ipsilateral intracranial arterioles. This maintains regional cerebral blood flow, but a point arises where the arterioles cannot dilate anymore. After this point, the patient enters a state of impaired or exhausted cerebral vascular reserve with limited or no capacity to vasodilate, and as a consequence, regional and global cerebral blood flow starts to decline. And in a very large recent meta-analysis, about 29% of patients with severe asymptomatic stenoses had evidence of impaired cerebral vascular reserve. Now, in our systematic review, we identified 10 studies which showed that 9 of the 10, had a significant association between asymptomatic carotid stenosis, impaired cerebral vascular reserve, and cognitive impairment. And it was very interesting to look at the changes so that there was a stepwise increase in the severity of cognitive impairment from normal cognitive function in patients with severe asymptomatic stenosis, but normal cerebral vascular reserve, who had no difference to controls with no carotid disease. And then when you went through asymptomatic stenosis plus unilateral impaired cerebral vascular reserve, they had increased cognitive impairment with the maximum cognitive dysfunction in patients with bilateral impaired cerebral vascular reserve. And patients with severe asymptomatic stenosis and impaired cerebral vascular reserve were significantly more likely to develop further cognitive decline over time versus patients with the same type of stenosis and normal cerebral vascular reserve. So when we ask the question, how might asymptomatic carotid stenosis cause cognitive impairment? Well, if we look at silent cerebral infarction, there's virtually no information on the relationship between asymptomatic carotid stenosis and silent cortical infarction. Silent lacunar infarctions, these are mostly unrelated to asymptomatic carotid stenosis, and there is no current supporting evidence to suggest that silent embolization causes subclinical damage that causes cognitive impairment. And it's highly unlikely that asymptomatic stenoses are involved in the pathophysiology of white matter hyperintensities, but there is more compelling evidence that patients with asymptomatic stenoses and impaired cerebral vascular reserve are more likely to get cognitive impairment. The second systematic review looked at the effect of carotid interventions on cognitive function in patients with asymptomatic carotid stenosis. Now, there have been two previous systematic reviews in 2008 and 2014. And these papers highlighted the problems. The sample sizes were too small. There was little consensus on the best cognitive testing strategies and no consensus on when you should time the post-operative testing. Most studies combine symptomatic and asymptomatic patients. And if you've had a previous stroke and you got an infarct, you will have impaired cognitive impairment, or you will have impaired cognition. And studies very rarely corrected for the practice effect associated with the repeat testing. So that in this second systematic review, we only included asymptomatic patients, and we divided the assessments into early and late. Early was comparing pre-operative to less than 3 months after surgery or stenting, while late was pre-op versus more than 5 months. And in the early, we had identified 21 studies with over 2,000 patients, and there were 24 cohorts. 11 were purely carotid, 10 were purely stenting, and 3 combined stenting and surgery. In the late reviews, 16 studies with 1,500 patients, there were 21 cohorts, and 13 of these had cognitive assessment for beyond 1 year after the intervention. And of these cohorts, 12 were purely endarterectomy, 7 stenting, and 2 endarterectomy and stenting combined. So when we analyzed the data, we looked at carotid interventions rather than outcomes after stenting or surgery. Now, this table summarizes the findings of this study, and I just want to make it a bit of clarity. The first 2 columns are the early assessments, and the right columns on the right are the later assessments. And what you've got to remember is that these studies report the effect of cognition on the cohort under study, not in individual patients. So we then divided into whether all domains or tests significantly improved, whether most domains were unchanged, but 1 or 2 tests significantly improved, where there were mixed findings, where some improved, but a similar proportion got worse, then no overall change in cognitive function, most domains unchanged with 1 or 2 significantly worse, and then all domains or tests significantly worse. So now if you look at the early results, you'll see that I've got the number of cohorts in the first column, and then this is translated into the number of patients affected. And you can see that the vast majority had no change in cognitive function. There were some with 1 or 2 tests improved, and less than 5% where everything improved, but only 1% became significantly worse, but about 17% had 1 or 2 domains that were worse. More importantly, let's look at the later outcomes. And what you can now see is that nearly 70% were unchanged during late follow-up, and nearly 25% were mostly unchanged or had one or two tests significantly improved. Most importantly, hardly anyone was made significantly worse, but similarly, hardly anyone was made significantly improved. Now, there was only one small study which evaluated whether hemodynamic status influenced postoperative cognitive function. And in this study, 11 patients with an 80 to 99% asymptomatic stenosis plus normal cerebral vascular reserve who underwent stenting had no change in postoperative cognition. And similarly, 6 controls with the same stenosis but who had impaired cerebral vascular reserve but who did not undergo stenting also had no change in cognition. But the 17 patients who had significant carotid stenosis plus impaired cerebral vascular reserve who were stented had significant improvement across all cognitive domains that were tested after stenting. Now, this is an interesting study, and it shows a suggestion that the benefit is maximal in patients with an impaired cerebral vascular reserve, but you can't change treatment strategies based on one small study. So what have the 2 systematic reviews told us? First of all, nearly all the studies reported a significant association between asymptomatic carotid stenosis and cognitive impairment, but this did not easily translate into a proven causal or etiological association. There's better evidence that there is a hemodynamic etiology here, but little evidence that lacunar infarction or white matter hypertensities are related to asymptomatic carotid stenosis. And future studies must evaluate the relationship between asymptomatic carotid stenosis, cognitive function, and ipsilateral cortical infarction. In the second systematic review, if we look at late follow-up, hardly anyone really had a significant improvement in overall cognitive function, and the majority were either unchanged or were mostly unchanged with improvement in 1 or 2 domains. But reassuringly, hardly anyone has significantly worse cognitive function after endarterectomy. So in conclusion, until new research identifies at-risk asymptomatic carotid stenosis subgroups for developing cognitive impairment, which is then improved by either stenting or surgery, and one of these might be impaired cerebral vascular reserve, or provides evidence that silent embolization causes cognitive impairment, then I'm afraid the evidence for expanding indications for carotid interventions in asymptomatic patients in order to prevent or reverse cognitive decline is lacking. But for those of you who are interested in developing future research, this is such a good area for relatively simple studies, provided they're performed carefully. Now, in the 2017 European Society guidelines, our recommendation was that until a causal association between severe asymptomatic carotid stenosis and cognitive decline has been established, carotid interventions are not recommended for the prevention of cognitive impairment in patients with severe asymptomatic carotid stenosis. Now, we are currently working on the 2022 carotid guidelines. I can't tell you what that recommendation will be, but you will see from the 2 systematic reviews that we've really not advanced very much in proving that asymptomatic carotid stenosis cause cognitive impairment and that carotid interventions can either prevent or reverse this. Thank you very much indeed.
Muchísimas gracias, doctor Naylor. Excelente exposición y muy claro. Tenemos preguntas del auditorio, si no, a mí, no sé, doctora Zurru, si quiere hacer unas preguntas usted, yo creo que tengo unas cuantas para hacer.
Sí. Primero agradecerle al doctor Naylor también por la charla, realmente impresionante la revisión. Y un poco preguntarles a ambos, digamos, ¿cuándo ustedes, hoy por hoy, con el tratamiento médico actual que hay, cambian a una intervención en un paciente asintomático? O sea, ¿qué parámetros tomarían para tratar a estos pacientes en la situación que tenemos hoy con el manejo de la patología? tanto al doctor David como al doctor Naylor.
David, you want to answer first?
Okay, well, I already said what I thought would be justifying intervention in asymptomatic stenosis would be evidence of high risk, like transcranial Doppler emboli, reduced cerebral vascular reserve. Ross's talk was absolutely excellent. I agree with everything. There is an issue, though, that you did not mention, which was the placebo effect in cognitive testing. And I absolutely agree that it is patients with reduced cerebral vascular reserve who are most likely to benefit from revascularization. But if anybody's going to do a randomized trial of patients with severe asymptomatic stenosis and revascularization, it must be a sham surgery trial because of you mentioned the practice effect, but there's also a significant placebo effect, and it's just not okay to go around assuming that if you improve cerebral blood flow, it's going to improve cognitive function.
In answer to the question that you posed to me, the European Society were the first society to publish criteria for what we termed high risk for stroke on best medical therapy, and there were 6 of them. And so patients who come in, the European guidelines, and that's the way I practice. If a patient comes in, I explain to them that the risks of stroke are much less now on modern medical therapy, but that certain subgroups are probably higher risk, so that if they have silent infarction on CT, stenosis progression, impaired cerebral vascular reserve, particularly embolization on transcranial Doppler, large juxtaluminal black areas on computerized plaque imaging, and large plaque areas, then we would offer or consider surgery or stenting in those patients. The one other group is that sometimes patients come to see me and they have already made their mind up that they want to have something doing. And I will explain to them why our rationale is as it is. But if they are adamant that they wish to have a carotid intervention, happily it happens rarely, then I will do it. It's just not worth the stress to the patient or me, but it is pretty rare. Most of the time I'm undoing all the stress is built up by people who are basically saying that there is a time bomb in their neck.
Sí, tal cual. Sí.
Una pregunta a ambos. ¿Ustedes consideran entonces en estos pacientes asintomáticos, a todos estos pacientes hacerle Doppler transcranial y estudio de reserva cerebral? Esa es la primera pregunta. Y la segunda pregunta es ¿qué ustedes consideran el paciente con estenosis carotídea bilateral asintomático si es un paciente que hay que ser invasivo?
Okay. Right. In my center, we've been doing transcranial Doppler since 1987, so that we're very experienced at it, and we find it easy. And you can measure cerebral vascular reserve using either inhalation of CO2 or breath holding, and looking at whether the velocities, the middle cerebral artery velocities can increase, because CO2 is a vasodilator. So there's a standardized methods for measuring cerebral vascular reserve. You can do more complicated with PET and SPECT, but it's actually easiest to do it with the transcranial Doppler. Now, there are a lot of people who don't like transcranial Doppler because they've never given it a chance. So for me, and I suspect David, it is a very important thing, and we find it quite easy to do. With regards to your second question, this is a very interesting subject. When we developed the 2017 European Society guidelines, we were also working in collaboration with the European Society of Cardiology on peripheral arterial disease guidelines, and one chapter was on carotid disease. So we had to get a consensus between both sets of guidelines. And as you can imagine, the main area of disagreement was over what was a high risk for stroke criterion in medically treated patients. And everybody was happy to accept the 6 that we came up with. But then there was the what happens with bilateral severe carotid disease, particularly contralateral occlusion. Now, in symptomatic patients, they are the highest risk group. You know, if you've got a contralateral occlusion and a symptomatic stenosis, that is one of the highest risk predictors for stroke, but it is not in asymptomatic patients. There is no published paper showing that significant bilateral disease is associated with a higher risk of stroke in asymptomatic patients. It seems completely wrong. It seems impossible. But that is, and this is what I said to the other people who are disagreeing with me. I said, that's fine. Show me one paper which is published that contralateral occlusion or bilateral severe disease increases the risk of stroke, and we'll add it. And nobody could find a single paper. Now, if your listeners are aware of one, please tell me, and I'll think again with our latest set of guidelines. But I don't know what David thinks about this, but I suspect he has the same viewpoint as me.
Yes, exactly.
Muy bien. David.
Yeah, so Ross, you mentioned using TCD to evaluate CBF reserve, and that probably is the easiest way. Another approach is to use Diamox.
Yeah.
With the CT cerebral blood flow.
Yeah, I think the key thing is that when we introduce impaired cerebral vascular reserve as a risk factor for stroke in medical patients, you know, that was a kind of small niche set of papers that were that, and not many people were using it as a high risk criterion. But if we can demonstrate that the hemodynamic impairment in asymptomatic patients is associated with cognitive impairment, then I think it makes it a more important test to do on patients, so that you're doing it in terms of trying to identify a high risk for stroke in the future and maybe a higher risk for cognitive impairment as well.
Yeah, I think for cognitive impairment, measuring CBF reserve is key. But I published recently a paper reporting that patients who had a high carotid plaque burden without stenosis had significant cognitive impairment. So carotid stenosis, high plaque burden are associated with cognitive impairment, but I think it's unlikely that it's causally related absent reduced cerebral vascular reserve.
I think this is an important point, because people are probably thinking, well, how can 95% of studies show a significant association between asymptomatic carotid disease and cognitive impairment, but you then can't prove how it happens? It may well simply be that asymptomatic carotid stenosis for the majority of people is a marker of something else. And I'll give you an analogy. For a long time, everybody thought that asymptomatic carotid stenosis was an important cause of stroke after coronary bypass surgery. But what actually, if you look at the data critically, a severe asymptomatic carotid stenosis is actually a marker of severe disease in the aortic arch. So it is a predictor of severe aortic arch disease, which is one of the principal causes of post-CABG stroke. So that if you look uncritically at just simply saying asymptomatic carotid disease, high stroke risk after CABG, all that is happening there is that where you have CABG patients with severe carotid disease, they're going to have awful aortas, and they're going to be more likely to have atheroembolism from the arch when you clamp it or cannulate it, rather than the asymptomatic disease is just a marker. And there may be something similar going on with these asymptomatic patients, like David talked about, with a high plaque burden, but no significant stenosis.
Yeah, so I think the evidence is pretty good that carotid stenosis or that endarterectomy in association with CABG does not reduce risk.
Different subject, but
Yeah, well, it's related.
Muy bien. Cristina.
Una pregunta más. Digamos, nosotros sabemos que los pacientes que tienen enfermedad carotídea moderada, severa, tienen un alto perfil de factores de riesgo y que en el último tiempo está aumentando la incidencia de demencia vascular, ¿no? Entonces, yo creo que parte de las dificultades podrían tener que ver con que estos pacientes tienen isquemias silentes bilaterales, no necesariamente del lado de las estenosis más significativas, y que probablemente uno tenga que ver, digamos, pruebas más orientadas a un hemisferio o al otro para tratar de ver si podría tener que ver con esto, más allá del compromiso de la reserva hemodinámica en forma severa, ¿no? Porque uno ve que estos pacientes se deterioran tanto por enfermedad de pequeña arteria como por la presencia de estas hiperintensidades periventriculares, y no necesariamente uno ve una carga lesional asimétrica que pueda manifestar algo. Quisiera saber la opinión de ustedes con respecto a esto.
Well, as I hope I've shown you in the presentation, there's been a huge amount of speculation and not enough good quality studies. And most people are adding 2 and 2 together and getting 8, rather than critically going back to look at how this can happen. So that I'm comfortable in my own interpretation that asymptomatic carotid disease has little or no involvement in white matter hyperintensity formation or lacunars, but they may well be associated with it because the risk factors are very similar: hypertension and hypercholesterolemia, etc., etc. For me, the glaring omission, and if I was advising somebody to do a new research project now, I would say we need to look more critically at the relationship between an asymptomatic carotid stenosis or a normal carotid artery and silent cortical infarction, and whether that, and you would have thought we would have had all that information already. It's not there. So that there are lots of gaps. All we can do is speculate just now about the relationship between asymptomatic carotid disease and dementia. All we can do is speculate because there is little hard evidence.
Mm-hmm.
Now, Ross did not mention the NUN study, which was quite an old study, but it showed that among members of a religious order in the US, the presence of 1 or 2 small lacunar infarctions at the base of the brain markedly increased the likelihood that patients with Alzheimer's were demented during life.
Yeah, I think you make a good point, and it's looking at the meta-analyses, and the problem is that they're all types of lacunar infarction, not just those with asymptomatic carotid disease. Lacunar infarction is a predictor of an increased risk of dementia, along with the white matter hyperintensities, and it's trying to find out how these happen, because I'm sure the nuns that you're referring to, I'm sure they lived a very pure and devout life and were not as naughty or bad as.
Yeah, one of the interesting things in that study was that one of the worst brains was in the head of the order, who was sharp as a tack until the day she died, but she had almost the worst Alzheimer's pathology, but no stroke.
Yeah. So much still to learn, David. I think, we're just we're just scratching the surface now of trying to understand this. And this is why I would reiterate with you, and it's on what we said in the 2017 guidelines, please, the situation is complicated enough as it is with trying to discuss stroke prevention in asymptomatic patients. Don't start telling patients that they need to have an operation to improve or reverse or prevent cognitive impairment, because I think you're doing a disservice.
Doctor Ferrari, tenemos algunas preguntas más, ¿podemos seguir? ¿Tenemos tiempo?
Sí.
Sí, tenemos tiempo de sobra y hay varias preguntas inclusive.
Acá tengo una pregunta del auditorio, lo tengo el doctor Fernando del Castro, que es cardioangiólogo del Cardiovascular Buenos Aires, y él me está anotando acá de que el tratamiento óptimo del paciente con estenosis carotídea asintomática severa incluye la utilización de rivaroxaban en el estudio COMPASS. ¿Qué opinión se merece el doctor Naylor y el doctor Spence?
Yeah, that study was in patients with peripheral vascular disease, and it is suggestive that low-dose rivaroxaban plus aspirin may be better than aspirin alone. But I think what's much more important is all the other factors: the Mediterranean diet, intensive lipid lowering, and all those other treatments that I mentioned.
Yeah, the other thing I would add, and I know that because I mean, we've been going through this in great detail, the COMPASS study, the subgroup analysis on patients with carotid stenosis showed no evidence that it made any difference. There was no statistical difference in that subgroup.
Les voy a hacer una pregunta yo en los pacientes asintomáticos. ¿Qué importancia le dan a la edad del paciente, su expectativa de vida, si tienen que ser intervenidos? ¿Y qué rol le dan a la mujer, sabiendo de que las complicaciones son mayores que en el hombre y en la mujer que tiene estenosis asintomática?
We got round this, you make a very, very good point. And the ACST was the only randomized trial which included patients over the age of 75, and they demonstrated that surgery conferred no significant benefit once you included the perioperative risk. And again, we debated this because a lot of people were saying, well, it's in the modern era, 80 is the new 60, and we shouldn't be so ageist. And we got round that by saying that, it's not unreasonable to think that if you're over 75 and you have high-risk plaque features or high-risk clinical features, then I don't think it's reasonable to deny you an intervention, provided you've got a 5-year life expectancy. But I would also similarly say, I'm 63. If I was a patient, I would say to myself, Ross, you need to wise up and start making changes to your lifestyle. You need to adhere to this, that, and that life. It's not just about cuts or stents to try and absolve you from your responsibilities. And I would explain to them that the vast majority are not going to have any strokes, even at the age of 60, by changing their lifestyle and taking best medical therapy. And we'll keep an eye on those. We'll keep an eye on the high-risk features during surveillance. Now, some people say to me, I can't cope with this. I just keep worrying. Okay, fine. Do an intervention. I don't, if they're getting so stressed out, it's pointless withholding it from them. But the vast majority of people, as I said earlier, mainly want some sensible discussion and a balanced discussion about what the risks and benefits are without scaring them.
Yeah, there's something that isn't often discussed, and that is the tendency to withhold lipid-lowering drugs in old people because they're old. And I've published 2 papers in the last couple of years reviewing the evidence that older people benefit even more than younger people from lipid-lowering therapy. And it's nonsense to withhold it. They should be treated intensively with lipid-lowering therapy, not just statins, but also ezetimibe. And there's even a paper from Japan reporting that among patients who were age 80 at enrollment and followed for 5 years, ezetimibe alone versus diet significantly reduced cardiovascular risk. So people should be using more ezetimibe, which is now approved in the European guidelines and the Canadian guidelines. I think ezetimibe should be used routinely with statins because ezetimibe doubles the effect of statin therapy, and it allows lower doses of statins with less adverse effects.
The other great news about statins is, notwithstanding its lipid-lowering effect, is that statins are MMP, matrix metalloproteinase inhibitors, and they stabilize the plaque in a different way to the functions they do in changing your lipid profiles. And there are many studies now showing how statins will demonstrate remodeling of the plaque and developing a more stable appearance on ultrasound compared to what might have been a bit more scary earlier-wise. There's a lot still to be done on that. David's done a lot of it himself, but statins are amazing drugs.
And they work very quickly.
Yeah.
Muy bien. Y Cristina, ¿alguna pregunta más?
Sí. Ustedes los dos marcaron muy bien de que cuando uno recibe a los pacientes en el consultorio de patología carotídea vienen muy asustados y uno tiene que tratar de explicarles bastante bien la situación. Mi pregunta es referente a que, digamos, en los pacientes que nosotros vemos en el consultorio, lo que vimos es que se redujo mucho el riesgo de stroke, pero siguen teniendo riesgos importantes en otros territorios. De hecho, En la cohorte, cuando vemos la mortalidad a largo plazo, lo vemos más asociado a la enfermedad coronaria o a la patología de la aorta que al accidente cerebrovascular. Digamos, la gran mayoría no han tenido eventos. Y algunos, bueno, se han operado porque la placa tenía signos de vulnerabilidad, como una hemorragia importante o la presencia de una floating plaque, digamos, con la posibilidad de hacer una embolia distal, pero o no retrogradaban con el tratamiento médico. La pregunta es, ¿cómo evalúan ustedes, digamos, y si han tenido o posibilidad de demostrar la reducción de eventos en otros territorios, dado que uno acepta que la carótida probablemente sea uno de los últimos que se afecta en estos pacientes?
Well, my 2010 paper in Archives of Neurology, intensive medical therapy reduced both stroke and myocardial infarction by more than 80% in 2 years. So all the vascular territories are improved. It's very interesting to hear Ross talk about these anxious patients who want intervention. I have not seen them. I have more than 400 patients with asymptomatic stenosis, and not one of them has said, "Doctor, I want something done because I'm afraid." I don't see it. Maybe the press coverage in Britain is different from in Canada.
No, I did stress that it was only a very small minority. There are people who've already made their mind up. The problem is Google and the other things just spread terror.
Yeah.
when they go and ask Dr. Google for his opinion, it's not always a balanced discussion of the problem. I think one of the things that I keep teaching my students and junior staff is that when you're trying to implement best medical therapy to prevent stroke in patients with asymptomatic carotid disease, that is very worthwhile. But actually, you're probably preventing that patient from having an imminent heart attack or dying of a heart attack in the next few years. More asymptomatic carotid stenosis patients will die of a heart attack than they will from a stroke. So that to me, one of the key things is as David has alluded to, you are preventing a package of issues, most notably stroke and myocardial infarction. And if we then identify high-risk features, and I'm not for a minute saying that the European Society got every high-risk feature right the first time round, but it was a stab, because I must admit, I used to get really fed up of guidelines stating you must only operate on highly selected patients, and then didn't tell you what they meant, so that everyone goes, well, what does that mean? And the problem is that if you live in a culture which is more there's a lot of medical legal, what I call censure or criticism, you're going to opt for the safest way out and just do what everybody does, so that everybody gets an operation or a stent without actually thinking. And the simple reality is, and we haven't done this presentation today, but for every 100 carotids that you do for asymptomatic carotid disease, at 10 years, 95% were unnecessary. Okay? 95, not 10 or whatever, 95% were unnecessary. And that's why we need to be more discriminating.
Tal cual.
Dos preguntas más. Una que quedó ahí, ¿qué opinan de la estenosis asintomática en las mujeres? Esa es una pregunta. Y después, que lo tengo al doctor Meyer ahí, yo soy cirujano vascular y soy quizás uno de los pocos que me gusta mucho acá en el país, el stent carotidio. Lo veo como muy poco invasivo, a pesar de que las cifras de stroke es mayor que la de endarterectomía. ¿Qué opinión le merece el stent carotidio en el paciente asintomático?
Okay, to answer that, first of all, the ACAS and ACST showed no evidence of benefit in women up to 5 years, but by 10 years, there was significant benefit. And this is again why when we published the 2017 guidelines, the key criteria was predicted survival more than 5 years, more than one risk factor, clinical or imaging. And then that covered women and men, okay? Because they've got the high risk features. I'm sure that women are still at slightly less risk of having a stroke, but by trying to be a bit more discriminating and identifying a higher risk cohort within the overall group, I think the discrimination between the ages and the sexes become less important. With regard to stenting, well, the ACST2 is about to report imminently. If we did a meta-analysis of I think there was 7 randomized trials, including asymptomatic patients, and the death and stroke rate was significantly higher after stenting versus surgery, but both were less than 3%. The stenting was about, I think it was 2.7, 2.8%. Now, the crucial thing will be to see what, first of all, ACST2 say, and then what CREST2 says as well, okay? So that, I mean, I think the one message that we can say with absolute certainty is that if you survive to 30 days without having a stroke after stenting, then the long-term outcomes, 5 and 9 years, are identical between stenting and surgery. The crucial period is the first 30 days. So it's patient features that determine whether you should choose stenting or surgery in the first 30 days. And because asymptomatic patients have much lower risk plaques, probably stenting is about the equivalent of surgery.
Yeah, but a key issue here is age. And there's a very good meta-analysis in Lancet Neurology by George Howard and others, showing very clearly that stenting is worse in old people and better in younger people.
Exactamente.
So that's a very important issue. But on average, the risk of stroke is higher with stenting than with endarterectomy.
Acá tenemos una doctora que está preguntando, creo que ya por parte lo han dicho, ¿sí? Tenemos una paciente femenina con una oclusión total de la carótida derecha y una estenosis severa de la carótida izquierda asintomática. ¿Cuál sería la recomendación con esta paciente?
My recommendation is to look for high-risk features such as microembolization on TCD, intraplaque hemorrhage, reduced cerebrovascular reserve. I have many patients with bilateral carotid occlusion who have done fine for years, 10 years, 15. Preventing carotid occlusion is not a valid indication for intervention.
All I would say is I would reiterate what I said to you before. Intuitively, you would think that those kind of patients are the highest risk, but the evidence is against that. There is no evidence that they are an increased risk category. And I would welcome, and as I said to you before, if you know of a study that says that I'm wrong, I would be delighted if you brought it to my attention.
Y la última pregunta, señor presidente, le digo al doctor Ross, que sé que estuvo viendo mucho, ¿cuál es el rol del TCAR en estos pacientes?
Well, we're going to find out, aren't we? I mean, the role of TCAR, the problem with the evaluation of TCAR, which looks a very innovative and very interesting technology, is that it's been so far used mainly on low-risk people. So speaking from my perspective, I want to see how good TCAR is when it's performed within 5-7 days of symptom onset of patients with TIA or stroke, because that's where you prevent most strokes in symptomatic patients. In asymptomatic patients, if you want my prediction, I suspect it's as good as endarterectomy. I suspect. The randomized, we will get more data from ACST2 and CREST2 on this when they start publishing the carefully adjudicated data, because all these patients will have had neurological assessments afterwards.
I would say we need more evidence, but my prediction is that in future, the only way that carotid stenting will be done will be TCAR. When you shove a stent into a tortuous, craggy carotid artery, you get microemboli into the brain, and that the study from Calgary showed that something like, I forget, it was 60% of patients had new MRI infarcts after stenting, and 7% of them had significant reduction of cognitive, of functional impairment. So TCAR, I think, is going to be better than transfemoral stenting.
With one caveat, I reviewed the Roadster 2 paper for Stroke, the journal, and I did the subsequent editorial. And that Roadster 2 study showed that you could take TCAR naive practitioners and teach them how to do it safely very quickly. But the crucial message, which was not picked up so much, was that if there was any non-compliance with medical therapy, TCAR was very dangerous. The risks of stroke were much higher in patients, particularly the symptomatic patients, but also the asymptomatic patients, if they did not adhere to the dual antiplatelet therapy and statin therapy. And that needs to be investigated further. So the message is TCAR, I think, will make a big difference, but your patients have to adhere to their medical therapy.
Claro.
Doctor Ferrari.
No, ya la verdad que en realidad me quedan siempre más duras. Nosotros realmente estábamos muy, como de alguna manera sigo el lineamiento de Ross, en el cual nosotros éramos mucho más agresivos, y yo creo que de alguna manera no se le negaba, entre comillas, no se le negaba una endarterectomía carotídea, inclusive a los pacientes asintomáticos. Evidentemente hay mucha o bastante evidencia que se está dando, como estamos diciendo ahora, de que probablemente muchos de ellos nosotros como cirujanos los tengamos que dejar aparte nosotros. Yo quería hacer una pregunta más. ¿En qué pacientes, en qué grupo de pacientes utilizaríamos realmente un stenting carotídeo? Teniendo en cuenta obviamente esos primeros 30 días sin mayor o menor complicaciones de tromboembolia, pero ¿en qué pacientes exactamente lo utilizaremos? Porque da la interpretación que cada vez estamos usando menos stenting, o lo vamos localizando en un grupo característico de pacientes.
Since we published the 2017 guidelines, there's been a lot more evidence. So these so-called high-risk endarterectomy patients, the criteria that were for that, most of them are not predictive of a higher risk of perioperative stroke. So that a lot of them were they were thought up rather than evidence-based, and a lot of them have been found. So the simple answer to your question is, we do not know yet which patients absolutely should have a stent rather than operation. And in asymptomatic patients, so for example, I would say with one caveat, if you've got a contralateral recurrent laryngeal nerve palsy, I would do a stent in that patient. But if they were asymptomatic, I would leave them alone. So the problem then is with these symptomatic patients where you need to do something. And certainly for me, recurrent laryngeal nerve palsy and people with really severe radiation injury to their skin and neck, fine. But for most of my radiation patients, there's no real problem with doing the operation at all.
Sí.
But there is a small
Ahí el stent es mejor.
whose necks are absolutely rigid, and in which case, fine. If they're symptomatic, we'll stent them, but if they're asymptomatic, we'll leave them alone.
Yeah, I would say that also a very high stenosis might
Yes.
be better stented, and a recurrent stenosis in somebody with a lot of scar tissue might be better stented.
Yeah, although the risk of stroke with a recurrent stenosis, again, it's very, very small indeed.
No, I would only talk, I'm talking about symptomatic recurrent stenosis.
Okay, all right, no, fair enough. Well, that's an interesting, I used to have this debate regularly, David, because if we were operating within the first 72 hours, which we normally do in Leicester, there's almost certainly going to be thrombus on the recurrent stenosis. And therefore, it's a balance, isn't it? You know, and so we would have in my group, there were one or two of us who would specialize in that kind of more difficult, unpleasant carotid surgery. and it's not something for everyone to do, but we would balance it up about whether it was safer to put a stent through a thrombus on a recurrent stenosis or whether it was to do an operation. And we would sit as a group and work it out what was best. There's no, the one thing I've learned with carotid disease is this adherence to a one-size-fits-all strategy is one of the reasons why we've got ourselves into a right bloody mess. And we need to think more around it to try and work out the solutions.
That individualize the therapy.
Absolutely. Absolutely.
Le completan estudios, o sea, en el cerebro tenemos mucha circulación colateral que puede proteger a otro territorio, ya sea por las arterias comunicantes anterior o comunicantes posteriores. La pregunta es si ustedes estudian el intracraniano en estos pacientes y qué importancia le dan al grado de circulación colateral que el paciente tiene.
To be honest with you, I don't pay that much attention, because if they've got impaired cerebral vascular reserve, that basically tells you that they've got an incomplete circle of Willis. So that for me personally, I don't use.
O sea, lo utiliza con la reserva.
The only times that's more important to me than whether or not the anterior communicator or the posterior is where. If they're symptomatic, most of my patients are symptomatic. So I would, in our practice, 92% of our carotid workload is symptomatic, and between 5 and 10% is asymptomatic. And we've got other criteria. So I don't pay much attention to the circle of Willis, to be honest with you. Maybe I'm wrong. I don't know.
Perfect.
Do you, David?
Some of my colleagues have published a bit about that, but I think the key difference is symptomatic or asymptomatic, high risk versus low risk. Those are the key issues. High risk for stroke.
Yeah.
So microemboli, intraplaque hemorrhage,
Sí.
reduced CVF reserve. I think that's more important than the circle of Willis usually.
I mean, the circle of Willis might become more important when looking more critically in patients with possible cognitive impairment. That will add to our knowledge, so that yes, I would. If I was doing research on this subject, then I would be looking at patterns of the circle of Willis along with impaired cerebral vascular reserve, etc.
Yeah.
Señor presidente, voy a hacer una última pregunta que quizás no es de pacientes asintomáticos, pero veo que hay 57 participantes y que muchos van a querer escuchar esta pregunta. Hemos tenido estos pacientes que hacen una ACV y siempre la conducta clásica nuestra es esperar un término de 4 a 6 semanas para revascularizar. Y las tendencias actuales quizás son de que si esa ACV no es muy grande, que conviene revascularizar dentro de los 14 días. ¿Cuál es la opinión que tienen ustedes con respecto al paciente sintomático con ACV y el tiempo de revascularización?
Excelente.
In my practice, if you've got a disabling stroke, which is a modified Rankin score of 3 or above, we use that in the UK. We don't really use the NIHH much. We would defer surgery until they've made a recovery, a significant recovery. If, however, the patient makes a rapid recovery, so they present with a stroke, they may have had thrombolysis, they present with a stroke and make a rapid recovery, then we don't wait 4 to 6 weeks, we will go ahead and sort them. Now, interestingly, there's a paper about to be published in the European Journal. Some colleagues of mine and myself, we did a meta-analysis of the risks of stroke after thrombolysis in endarterectomy and stent patients. And the lead author is a guy called Stavros Kakos, K-A-K-K-O-S. And he's a genius and did a meta-regression analysis and shows that for you to get the best outcomes, you probably have to wait 6 days after thrombolysis in order to be able to do endarterectomy with a 6% death and stroke rate. Because if you have a thrombolysis and you operate very quickly, then the risk of stroke is much higher than you would expect. So
Hemorrhagic stroke.
No, yeah, mainly hemorrhagic, David. But a lot of the studies that looked at it didn't actually, they just recorded stroke.
Yeah.
I mean, I'll tell you, the National Vascular Registry in the UK, we've just published the largest series of endarterectomy after thrombolysis with 1,200 patients. And we couldn't tell you whether there was an increased risk, but we couldn't tell you whether it was hemorrhage or ischemic because they were lumped together as one. It was a big lesson.
And what about the number of days after the event?
Well, it's the studies that have been published don't tend to tell you the number of days after event. They tell you the days after lysis. That's
pretty much the same.
Yeah, I mean, I'm sure you're right. But so that what they showed was that if you accept that a 6% death and stroke rate is an acceptable risk in patients undergoing endarterectomy, in symptomatic patients, which I think it is if you're operating very quickly, then in order to reach that 6% threshold, you have to wait about 6 days after lysis. So that, for example, if you operate within 2 days, I think the death and stroke rate was about 10%. If you waited about 3 or 4 days, I think that risk was about 10%.
Then you might have to wait longer with bigger strokes.
Oh yeah, but you don't operate on the biggest strokes, David. I think that's my caveat on that. That if you've got a disabling stroke, then we would not rush to intervene. And I have to say that in my experience, 50% at least never come to an operation because they never make a good enough recovery.
Because there's not much to gain.
Well, yeah, the big challenge for me, and I'm sure it'll be interesting to hear what the surgeons say, is that when you've got somebody with a disabling stroke and a significant stenosis, and I'll see them on the stroke unit and I'll say, I tell you what, we'll keep an eye on him, but we're not going to do anything just now. And then they ring me up to say, well, he's made a partial recovery, not that much, but he's had another event, another embolic event. And that's the ones that I find most difficult to decide what to do. Because it's a really difficult balance then. My one piece of advice is if you feel motivated to do an urgent operation on those people, you must have absolutely aggressive control of blood pressure afterwards, because if you let the blood pressure go up unrestrained, then you're going to have a massive intracranial hemorrhage and it will have been pointless.
Una pregunta más. A esos pacientes que ustedes difieren porque tuvo un stroke más severo y que se van a revascularizar de acuerdo a su recuperación, ¿el tratamiento médico lo dejan con doble antiagregación y estatinas en altas dosis todo ese tiempo? Porque eso, digamos, hoy por hoy el stroke recurrente precoz es menor que lo que se informaba en el trabajo original de Rothwell. Entonces, quizá uno podría a esos pacientes dejarle un tratamiento más agresivo hasta ver si va a ir o no a una revascularización.
We would have all people with ischemic events, we would have them on dual antiplatelet therapy and high dose statin. And what's been interesting, I mean, the world is moving into a different place. With COVID in the UK, we got absolutely hammered with COVID last summer, and most non-emergency operating stopped. And we stopped operating on elective aneurysms. We stopped doing carotids unless they had recurrent symptoms on medical therapy, and all of them were put on dual antiplatelet therapy. There was a national policy, dual antiplatelet therapy and statins, and it was quite surprising how few had recurrent stroke while we were trying to get over the pandemic. And it wasn't because we couldn't do an operation. What happened was in the UK, a lot of the operating theatres were turned into intensive care units, and a lot of the anaesthetists were now acting as intensivists, so that there just simply wasn't the manpower to be able to staff the case. And also, if you put a patient on a ventilator who's got COVID, you're going to basically kill the next one that goes onto the ventilator afterwards. So, you know, so it wasn't a planned thing, but it's making us perhaps totally rethink strategies in the symptomatic patient. You know, the dual antiplatelet therapy seems to make an immense difference. Do you agree with that, David?
Yes.
Yeah.
But I wouldn't just use statins. I would use ezetimibe as well.
Bien.
Doctor Ferrari, bueno, acá creo que hemos concluido y hemos aprendido muchísimo en el día de hoy.
Sí,
La verdad que realmente
excelente.
hemos aprendido una gran cantidad de cosas y creo que de alguna manera los cirujanos también nos cambia un poco la perspectiva de cuándo o no tratar en forma más agresiva como nosotros, ¿no es cierto? Así que bueno, si no hay más preguntas, los podemos dejar libres a Ross y a David y por supuesto agradecerles lo que han hecho porque realmente ha sido realmente fantástico, ¿no es cierto? Así que no hay más preguntas, ¿no? Thank you very much, Ross. Thank you very much, Spence. Okay, bueno, gracias por todo, gracias a todos los que han participado y bueno, esperemos vernos la próxima vez. Muchísimas gracias.
Muchas gracias a ambos. Excelentes exposiciones.
Saludos.
Gracias.
Gracias, Spence.
Take care.
Gracias.
Thank you very much. See you again sometime, hopefully in person.
I hope so.
Sí.